General for Primary Healthcare in the National Department of Health.
Good morning, Honourable Chair, honourable members, Minister, Deputy Minister, DGM colleagues. I am Nicholas Crisp and I am the DDG responsible for National Health Insurance. Thank you.
Good morning, Minister. Good morning, Honorable Chair and members of the committee. My name and surname is Ramthelani Marewani, Acting Deputy Director General for HIV/AIDS, Maternal, Child and TB. Thanks very much.
Dr. Tulare?
Good morning, honorable members. My name is Aquina Tulare. I'm the technical specialist for the National Health Insurance. Thank you.
Thank you. Andre?
Good morning, honorable members. My name is Andre Venter. I'm the Chief Director for Finance in the National...
Can't see you. We can't see you. Yes, that's better.
Oh, sorry, apology, Minister. Good morning, Honourable Chair and members of Parliament. My name is Andre Venter, the Chief Director for Finance in the National Department of Health. Thank you.
Thank you, Ms. Zondi.
Good morning, Honourable Chair, Honourable Members, Minister, Deputy Minister. I am Thuli Lezondi, the Chief Director for Health Information, Research, Monitoring and Evaluation, Epidemiology and Surveillance. Thank you.
Thank you, Ms. Gambu. Ms. Gambu?
Thank you, DG. Good morning, Minister, Deputy Minister, Honourable Chair. I'm the Chief Director for HRMND. My name is Q Gambu. Thank you.
Ms. Sibanyoni? Koketo?
Thanks, DG. Good morning, honorable members, Minister, Deputy Minister. I am Koketso Sebanyoni. I am the Director responsible for planning in the department.
Mr. Khatla?
Good morning. Good morning, honorable members and the chair. Good morning, Minister, Deputy Minister. My name is Joe Khatla.
Unmute your what you call Khatla. Unmute your video, please.
It says unable to access camera, Minister. I don't know what the problem is, but yeah. I'm not sure why it's not opening the camera. The message I'm getting is just unable to access camera. But my name is Joe Khatla. I'm assisting the minister. I'm the PLO, Parliamentary Liaison Officer. I'm sure I'll be active with members quite often. Thank you very much.
Ms. Nowatemba?
Good morning. My name is Nowatemba Mkise. I'm the Deputy Director, Parliamentary Services in the Office of the DG. Thank you.
Thank you, Honourable Minister. It looks like we've covered everyone that is on the platform. Thank you. I'll hand over to the Minister.
Yes, thank you very much, DG. Honourable members, I'm sure you have seen us. Now you'll allow us to speak without appearing here because the reception won't be that good. Perhaps when the DG presents, he will be unmuting his video so that you can see him during the presentation, unless the reception becomes poor. But I will ask that DG show him his face so that you can see him during the presentation. Otherwise, honourable members, I'm giving over to the DG immediately to start giving us the annual performance plan and the presentation. Thank you very much, DG. You have got the platform.
Thank you very much, Honorable Minister, our Deputy Minister, Honorable Chair and members. We will be taking through the committee through our annual performance plan for 2024-2025, and I hope my presentation is visible on the other side.
It is visible. We can
see. In terms of this just strategic overview, this annual performance plan was tabled. Thank you very much. This annual performance plan was actually tabled in March 2024, and we used the medium-term strategic framework 2019 to 24. And focusing on, which is number 2 of the 7 priorities of government, which is education, skills, and health. And our own vision is a long and healthy life for all South Africans. And what impact
Chairperson, we can't hear you.
Have I lost the DG or have we lost all of us?
We have lost the DG, I think. Chairperson?
Yes,
Can you hear me?
Secretary, yes, I can. I don't know.
Yes, I think we have lost the DG there.
All right. Is there one of the others?
Let's try to get him.
Yeah,
because,
please.
Yeah, let me
Minister.
try to get him. Yes, thank you.
All right.
I can't get the DG. Chairperson, hello, Chair.
Yes, Minister.
Yeah, we're trying our best to trace the DG I don't know why we can't get him. I said they must look for the CFO because they were sitting in the same venue. But because we can't get them, I've asked the DDG for primary healthcare, Ms. Jeanette Hunter, to take over the presentation. But now,
Thank you.
she has not been put in as a host. I'm asking the members here, anybody who can put the presentation, please put it. Ms. Jeanette Hunter will take over until the DG comes back because we don't know what's happening.
Thank you, Minister. So Ms. Hunter can proceed.
Thank you, Chair. Thank you, Minister. Ms. Zondi, are you able to share this presentation, please? I don't see Ms. Sibanyoni either now. Koketso, are you on?
Ms. Hunter, I am in the meeting. I will share for you.
Thank you, madam. Just put on slide mode, please. Chair and honorable members, so we're presenting our annual performance plan for 2024-2025 to you. I hope you can hear me because I'm also using my phone. We have network problems in our building, and I think that is what happened to the DG. Am I audible, Chairperson?
Yes, you are, Ms. Hunter. You can proceed.
Thank you. Please proceed, Koketso. Our medium-term strategic framework for 2019 to 2024 as a government priority 2, ours is number 2 in terms of the 7 priorities, and it falls under education, skills, and health. And from there, we derive our vision of a long and healthy life for all South Africans. And with the following impacts, life expectancy of South Africans improved to 66.6 years by 2024. And we are aiming to move this to 70 years by 2030. Universal health coverage for all South Africans. We need to achieve this progressively, and we will need to show how we have moved from 2015, when this was included as a sustainable development goal. We'll have to show how we improved by 2030 is the target date. And as everyone in the meeting knows, South Africa is going to improve its universal health coverage through implementing the national health insurance. Next slide, please. In the context of the National Department of Health, and this is the context within which we place our 2024 annual performance plan, and it is that our life expectancy has improved since 2022, despite the reversal that was made by COVID-19. Over those 3 years of COVID, our life expectancy declined, but one can already see in 2024 the improvement since then. Central Chronic Medication Dispensing and Distribution Program, which enables collection of medicine parcels for stable patients at pickup points of choice for people, has contributed positively to access to treatment and reducing congestion at health facilities. We have introduced pandemic prevention, preparedness, and response as a 10th pillar of the Presidential Health Compact. South Africa did fairly well compared to other countries during the COVID pandemic. And this is because we had always had in our 52 districts outbreak response teams. What we did during COVID was to strengthen those district outbreak response teams by combining them with our district specialist teams. But there were still weaknesses in terms of resources and etc. And what we want to achieve through this 10th pillar is to strengthen our pandemic prevention, preparedness, and response even more, so that we can cope better with future eventualities in terms of outbreaks. The burden of non-communicable disease continued to increase, largely due to adoption of unhealthy lifestyles. And this really needs attention. Our focus is going to be strongly on how to effect behavior change in terms of South Africans adopting healthy lifestyles to turn around this increase in non-communicable diseases and mainly diabetes, conditions related to hypertension, and both of them are exacerbated by obesity. And then, of course, there's cancers, and mental health is also on the increase in South Africa, and we're really going to have a huge focus on that. The department remains committed to continue with its efforts to progressively narrow the gap of inequalities in our health system through the implementation of the National Health Insurance, as I've also mentioned previously. Next slide, please. Our key focus areas are as follows. The National Strategic Plan for HIV, TB, and STI, which was launched in 2023, will drive key interventions towards achievements of the 95-95 targets. So as much as the department is going to have a strong focus with regard to healthy lifestyles to reverse the increase in non-communicable diseases, we cannot take our eye off HIV prevention, tuberculosis prevention, and STI. The country's done very well. What has mainly driven up our life expectancy is the gains we made in the area of HIV and TB. And that has to be sustained, and we will further improve it. So we're going to speak in one voice about turning around the increase in non-communicable diseases, as well as our key communicable diseases, which remains HIV and TB in this country. Key interventions to aid improvement of quality of healthcare, maintenance and refurbishment of our health infrastructure remain key to support service delivery and improve access to care. One of the main frustrations of health workers is when they do not have the proper spaces to work in, proper spaces that lend to proper workflow and prevent frustrations for them and the patients. So infrastructure will remain top of the agenda. Community engagements to promote participation and aid responsiveness to health needs is going to remain important. We will sustain the reduction in maternal and infant mortalities, capacitating critical functions for the implementation of the National Health Insurance, hospital strategy to guide leadership, management, and governance of hospitals. Next slide, please. You can move to the next slide. So in terms of Program 1, that is the Program for Administration, they have the overall purpose to provide a management of the department and centralized support services. And key there is that we will strive to maintain our unqualified audit. And we will also strive to bring the number of invoices paid after 30 days to 0. And then in terms of health promotion and community participation, we will increase the number of health promotion messages broadcast on social media. We will increase number of visits of our leaders in the department to health facilities, and then the number of community engagements on health programs as well. Then we want to improve our employment equity targets to what we see there, that in terms of women, we want 50% representation, 30% representation of youth, and then 2.5% representation of people living with disabilities. Next slide, please. Program 2 continued. Another goal of Program 2 is to achieve universal health coverage by improving the quality and coverage of health services through the development and implementation of policies and health financing reforms. And there we're looking at the number of medicine parcels delivered to pickup points. That is, this CCMDD program is key in improving access for our communities and making it convenient for our communities to get their treatment, especially their follow-up chronic medication. Accreditation framework for health service providers.
Excuse me, Chair. Excuse me, Chair. Sorry for my intervention. Colleagues, can I ask, because we are having new members in this committee, actually we are a new entity, all of us together, can we avoid abbreviations, Jeanette, and make sure that we explain all these abbreviations in full. You may then use them later when people understand what they mean. We have just mentioned CCMDD, and I don't think 90% of the audience here understand what you're talking about. Please.
We'll do that, Minister. Thank you, Minister. The CCMDD stands for a centralized chronic medicine distribution and delivery. So similarly as to what happens to individuals who use GPs in the private sector, when you are on chronic medication, you would usually get a script that lasts for 6 months, and you do not have to go to your GP or even a specialist on a monthly basis, but you simply would then get your repeat medication at your pharmacy of choice. So what we do for the communities in South Africa is the same. We're depending on how stable the person is in terms of, for example, their diabetes, or for example, their hypertension. We will give them scripts for 2 months, 3 months, 4 months, up to 6 months. And their repeat medication is delivered to a place of their choice. They would choose if they want their medication at their nearest pharmacy, if we must deliver it to a center in the community where they live. We also have community health workers deliver the medication. And then some of our patients come to our facilities. We have what we are calling the pillar boxer, where the patient gets an SMS on their phone with a code. They come to the boxes at the clinics, they put in the code, and they get their medication like this. This program has really brought a lot of satisfaction from the patients using our services, but it's also helped us to take off the pressure of the numbers of patients that people in the clinics have to see, and this further drives up the quality of our services. This next point about accreditation framework for health service providers is another point and another important intervention for improving access, because the team working on the NHI, Prof. Chris and team, would be looking at accrediting service providers within public and private sector. But the accreditation is very important to ensure the quality of the service, and that the South African populations receive services in terms of agreed upon preset standards, where we also use the capacity of the Office of Health Standards Compliance to first certify, and then the NHI team will come after that and accredit these services. And this is all in the interest of providing safe care to South Africans. Then the team working on the NHI is looking at the capitation model as a methodology of paying for services. And there is a lot of advantages around capitation as a funding model for service providers, in that it could allow the service providers to provide more holistic care instead of looking at people as a procedure, instead of paying them for seeing someone for flu or paying them for healing a fracture. You actually pay the service provider per the number of people that they see, so that they see the people as a whole person and look after someone's health, whether they have a physical ailment together with mental health and other comorbidities as well. Then our electronic medical record is going to be very, very important in terms of having a longitudinal record of patients. I was talking earlier about turning around the high numbers of people suffering, for example, from diabetes or from hypertension. It is only an electronic patient record that will enable us to know on what date was someone diagnosed with diabetes, what treatment did they get, Are they coming for their repeat medication? Is the medication even helping to drive their sugar levels down? So the patient record is in process of being developed, and it's really going to be a game changer for health in terms of stepping up clinical quality so that we can have information about what South Africans are suffering from and how well is the health system doing in attending to the conditions that South Africans are suffering from. And of course, for all this, we need our essential equipment. We need it for diagnostics, but we also need equipment sometimes in the treatment of health conditions for which people seek help at our facilities. Next slide, please. Program 3 is the program that look after our health programs, and their purpose is to develop and support the implementation of national policies, guidelines, norms, and standards, and achievement of targets to decrease morbidity and mortality associated with communicable and non-communicable diseases. So in the area of HIV and AIDS, they will be looking at the number of HIV patients enrolled on the differentiated model of care. This is also a model that aims to take care to where people live, work, and play, and to tailor care to the individual person's need. Then the number of primary healthcare facilities with youth zones. We want to keep our youth healthy while they are healthy, and we want to keep them informed, and we want to improve health-seeking behavior from our youth, and these youth zones have the intention of providing youth-friendly services. Then when we come to tuberculosis, we're looking at that DS stands for drug-sensitive tuberculosis client treatment success rate, and we want to increase that to 83% in South Africa. And then the multi-drug resistant TB, which is more difficult and more lengthy to treat. Patients go on a longer period. We have a slightly lower target there because our targets are based on our current success rates. And then the number of people started on TB, we want to find at least additional that 2,221,941 patients in this year. When it comes to maternal, child, infant, and neonatal health, we're looking at the number of districts that's introducing the human papillomavirus screening for cervical cancer. And then, so we want to increase those districts to 18. And then the number of districts with non-polio acute flaccid paralysis detection rate of over 2 per 100,000 children under 15 years. So we know that South Africa has eradicated polio. I don't know if there's any members in this meeting as old as what I am, but I remember growing up with other children who were affected in terms of arms and legs with polio, and you don't see that anymore. That is because of the success of South Africa's vaccine program. And South Africans would know that there was a lot of noise during COVID about efficacy of vaccines. And in some ways, that debate around the COVID vaccine has even made negative inroads into our immunization program for children. And it's important that we turn this around and that every member of this committee recognizes the importance of the child immunization program to keep our children healthy and to allow them to grow up into healthy adults. And so this is why we have this target to drive down any detection in terms of polio, even to detect it and to attend to whatever problems they may exist in this area so that South Africa remain polio-free. Next slide, please. Malaria, this is still program 3 continued. So another goal that they have is to develop and support the implementation of national policies, guidelines, norms, and standards, and achievement of targets to decrease morbidity and mortality associated with communicable and non-communicable diseases. Malaria, we also do not have a big problem with malaria in our country, but our neighboring countries do have problems with malaria, and we often have imported malaria cases. But malaria can become a very debilitating, if not fatal, condition. So we also want to drive malaria down to 0 in this country, and therefore we have this program where we clear out the organisms, namely the mosquito that causes malaria. We call it the Foki clearing program, and we combat the existence of the larvae, the eggs laid by the mosquito, as well as the mosquito, by treating these areas with certain chemicals. And so we are going to implement this year, this Foki clearing program, in 4 of our sub-districts, and those are the sub-districts that may be problematic in terms of malaria in the country. Screening for non-communicable diseases, we will drive those numbers of persons screened, 16,700,000, ensure that at least 16,709,215 persons are screened with regard to diabetes, and then the number of clients screened for hypertension to 10,161,506. Mental health, we need to increase the number of state patients admitted into designated psychiatric hospitals to 200 for this year. These are individuals who commit crimes and are then found to be mentally ill and therefore cannot be held criminally liable for the crime that they have committed, and they do need to be admitted into a designated psychiatric hospital where rehabilitation start to sometime down the line be able to allow them to live in society again. Non-communicable disease campaigns, we are targeting to have 4 large non-communicable disease campaigns for this year, and this is over and above the number of health talks we aim to give on local community radio stations, on TV, and other media platforms. Then compliance with food service policy. We have in the past received a number of complaints about the quality of food at our state hospitals, and we've been working on this for the past 3 years to turn the situation around and ensure that South Africans, when they need to be hospitalized, receive nutritious food and also food that they are satisfied with. So we will be doing inspections in 351 hospitals. This is 70 more than what we have done in the previous year to ensure that the food comply with food service policy and standards. Next slide, please. Program 4 has the purpose to develop and oversee implementation of legislation, policies, systems, norms, and standards for a uniform, well-functioning district health system. The members of the committee will know that South Africa is divided into the 9 provinces, and across our 9 provinces, we have 52 health districts. And that is because South Africa believes in a decentralized model. We want to take the management of health services closer to where people live. And South Africa has further even divided these 52 districts into a number of sub-districts as well. And so this program, Program 4, looks at the service environment quality. So it looks at whether we have enough space to accommodate the numbers of patients we need to see in our primary healthcare facilities, and that include the district hospitals. Do we have equipment? Do we have medicines? Do we have enough staff? Does the staff, are the staff trained? Do the staff follow the proper procedures when it comes to caring for patients? And so here we have the target of increasing the district hospitals that qualify as ideal to 25, and the number of primary healthcare facilities that qualify as ideal to 2,700. We also believe that the quality within the primary healthcare facilities is improved through having strong community outreach programs. And in South Africa, we use our community health workers to do outreach in the form of household visits. And for us, especially the health of mothers and children become very important with these outreach services to locate possible pregnant women, to find out if they know that they have to go and book at antenatal clinics and that they have to visit the antenatal clinic regularly to have a healthy pregnancy, to, at the end of the day, give birth to healthy babies. Also to make sure that children are immunized, find out if no one in the household perhaps has a communicable disease, maybe have TB that needs to be attended to, and also looking at the mental health of people in the household so that they can be referred early and get treatment early and be stabilized on treatment, if not return to good health. And so our target is to do 14 million household visits in this year. In terms of environmental health, we are going to update the assessment tool for compliance with environmental health norms and standards. And the number of metropolitan and district municipalities that will be assessed for compliance to national environmental health norms and standards will be 10. And then we have a target for emergency medical services that says number of provinces assessed for compliance with regulations relating to standards for EMS will be all 9 provinces. Next slide, please. Program 5 is the program for hospital systems, and they have the purpose to develop national policy on hospital services and responsibilities by level of care and ensure that planning, coordination, delivery, and oversight of health infrastructure meets the health needs of the country. So in terms of hospital systems, they are going to draft a hospital strategy. And in terms of the National Quality Improvement Plan for hospitals, they are looking at the percentage of hospitals implementing the National Health Quality Improvement Program, and they want to make sure that at least 100% of the hospitals have started. And then along the line, we will see where the hospitals move to, but 100% of the hospitals must be on a quality improvement plan. In terms of health infrastructure, the number of facilities to be constructed or revitalized, they're looking at 42 primary healthcare facilities and 50 hospitals. And then the number of public health facilities maintained, repaired, and or refurbished, 400. Honorable Chair and honorable members, this maintained and repair refers to health facilities in a poor state. We are advocating and we are driving as health a strong proactive maintenance program, because we know in South Africa there is a problem, especially in the health sector, of our building new health facilities and they are not maintained. And we are turning this around through setting up proactive maintenance teams in each of the 52 districts that should do outreach to the facilities to make sure that minor repairs are done before those minor repairs are neglected and then lead into major defects in a building. Next slide, please. The Health Systems Governance and Human Resources. This is Program 6, and they have the purpose to develop policies and systems for planning, managing and training of health sector human resources, provide oversight to public entities and statutory professional health councils. In terms of public entities and councils, they want to have the following output, and that is that boards and councils appointments are made before the expiry of their terms. And here we're talking about the South African Health Products Regulating Authority, that is SAPRA. We're talking about the National Health Laboratory Services. And then someone has to help me with SADTC. What is that? Koketso, do you know? Just shout quickly.
Jeanette, South African Dental Technicians Council.
Thank you, Nicholas. The South African Dental Technicians Council. These are the entities that this program in the National Health Department has to look after. Then the number of public entities, audit action plans monitored. They want to look at 5 of them. In terms of nursing services, they're going to look at the number of differentiated nursing education and training plans developed. And those would be 9 for the 9 provinces. And in terms of food control, they're looking at in terms of the food labeling regulations to draft a set of final food labeling regulations submitted to legal services. Honorable Chair and honorable members, this is a very important facet of keeping South Africans healthy. And as I've spoken earlier, that we need to drive down this increase in non-communicable diseases, especially led by cancers, diabetes, and conditions relating to hypertension. And for all those conditions, obesity is a strong risk factor. So that South Africans need to become educated in terms of what they are eating and what they are drinking, especially when it comes to high salt intake that exacerbates hypertension, high blood pressure, and also to increase blood sugar levels that lead to obesity and then diabetes. Through this regulation, we want to make sure that producers are honest about the content of food and that food is clearly labeled, so as to enable South Africans to make healthy choices in terms of the food that they buy and the food that they eat. Next slide. Next slide, please. Oh, there we are. So we've covered our programs and we've arrived at a summary of the key outputs. And so to remind the Honorable Committee that in terms of Program 1, we are promising to strengthen financial management to ensure that valid invoices are paid within 30 days, improve the health system responsiveness through community engagements. In Program 2, what we want to achieve is to implement critical functions to enable the implementation of the National Health Insurance. Program 3, access to medicine should be improved through that decentralized program. Progress towards tuberculosis should be made through accelerating the improvement of treatment success rates. And we need to screen for non-communicable diseases so that we can detect them early and that people can be put on treatment early. I think everyone knows that a neglected high blood pressure can lead to a catastrophe for an individual when that leads to a stroke. Whereas if someone could have been diagnosed early and put on the right treatment, their hypertension could have come to controlled levels such that they don't have incidents like cerebral vascular accidents that's also otherwise known as a stroke. In Program 4, we want to make sure that we increase community outreach through household visits, tracing and linking patients to care through those household visits. Program 5 will continue to focus on health facilities maintenance and refurbishments. And Program 6 will improve the governance and through the governance, of course, the functioning of our very necessary entities. Next slide, please. CFO, are you going to talk about the budget? Is the CFO back on, colleagues? I can't see who's on the platform.
Yes, he's here.
Thank you, DG. Can CFO take over, please?
Thank you.
Thanks, DDG. I'll go through the few slides on the allocation. The next slide. On the slide, we show the funds allocation in the National Department of Health per program. The total funds allocation to the department is 62.2 billion. On the slide, we also show the same allocation in terms of the source of funding as we received from National Treasury. In terms of the voted funds is 1.2 billion. The earmarked funding, 2.4 billion. And the conditional grants, 56.3 billion. And we also have the indirect grant in the National Department with a value of 2.1 billion. So that makes the total allocation. We also show the same allocation in terms of the programs from administration, NHI, program 3, 4, 5, and 6. On the next slide, we show the same allocation in terms of the economic classification. So what is important is that in terms of compensation of employees, we have the allocation of 694 million. Our goods and services is 1.7 billion, and transfers 58.3 billion. So what I would like to indicate, Honorable Chair, is that the 58 billion on the transfers, so it's the money that doesn't get spent in the National Department, is the money or the funds that we transfer to the provinces and the NGOs and the entities, which will indicate as we proceed. And the allocation for capital is 1.4 billion. That gives the total allocation of 62.2 billion. And in terms of the COE, next slide, there has been a reduction of 15.9 million from the baseline. And also just to indicate that in terms of the compensation, it's only the appointment of employees in the National Department of Health. So it doesn't include the appointment of employees in the facilities, which is the hospitals and clinics in the provinces. In terms of goods and services, there was also a reduction in the baseline of 146. And in terms of transfers and subsidies, as I indicated, the money that we transferred to the provinces in terms of conditional grants, 180 million. And also a net decrease of 139 million, resulting from the decrease of 175 million, and also an increase of 26.3 million, which was shifted from the Department of Science and Innovations. The next slide. The next slides, they are going to show the allocation per each program. So I'll also indicate where the funds goes to the NGOs and the provinces. From this slide, you will see we have medical legal committee of 5.8 and also the SAICA program under the earmarked funding. So those are the funds that we use to assist the provinces in terms of dealing with the medical legal, and also either SAICA program is supporting the provinces in terms of financial management. And the total allocation is 759.5 million. On the next slide, we then show this allocation in terms of the economic classification. So that 10.7, it combines those two programs that I've indicated. On program 2, we have the total allocation of 1.3 billion. What is important in this slide, under health financing and NHI, we have below, we have National Health Insurance Conditional Grant. So on the conditional grant, Honorable Chair, those will be the funds that we transfer to the provinces, but we will also indicate the allocation per province towards the end of the slides. So that 455 under NHI is the allocation relating to HP contracting and also the mental health that we support the provinces. We also have the NHI indirect grant, where we also, the indirect grant is the funds in the National Department. So we have the allocation for the patient information system. We have the allocation for medicine stock systems, the internship and community service. and also the CCMDD, which the DDG has indicated during the presentation, and the Ideal Clinic, and also the quality improvement and the GP contracting capacitation of 103 million. Then on the next slide, we also show this same expenditure in terms of the economic classification. So you'll see the 455 million, it's under the conditional grants. So those are the money that will transfer to the provinces. In program 3, we have under HIV and AIDS, we have a district health program grant. So that component under conditional grant of 24.7 billion. So it's mainly for HIV and AIDS and the TB programs, the money that we transfer to the provinces. Below under earmarked funding, we also do have the allocation to the NGOs, the Lifeline, the Love Life, Soul City, and also for condoms, SANAC, and also other HIV and AIDS NGOs. So that would be the total allocation as we have indicated, and also the sub-programs which are funded under the voted fund to the total of 25.3 billion. On the next slide, we will also show that same expenditure in terms of the economic classification with that 24.7 to be transferred to the provinces. Under program 4, primary health care, we do have a district health component to the value of 3.2. Under the district health component, that's where we also find in the community health workers in the provinces, the malaria programs. In terms of malaria, it will be Mpumalanga, Limpopo, and KZN, those 3 provinces. We also do have the HPV programs within the district health component conditional grant of 3.2, but the total allocation to the program is 3.3 billion. And therefore, in the next slide, we show that same expenditure in terms of the economic classification. Under program 5, program 5, which is hospital services, we also do have the allocation that goes to the provinces in terms of the health facility revitalization conditional grant, which is for infrastructure to the value of 7.1 billion. And below there, we also do have under hospital services, the NTSG, which is the National Tertiary Services Conditional Grant to the value of 15.2, which it does also include the oncology component to support the provinces in terms of tertiary services. And we also do have under indirect grant, the 1.4 billion. That is the indirect grant, which is implemented by the national department in terms of supporting the provinces in terms of the infrastructure. Then the next slide, we will show the same expenditure in terms of the economic classification with the total of 22.4 billion going to the provinces, but then with the total allocation within this program of 23.9 billion. Under program 6, health systems governance and HR, under the earmarked funding, Honorable Chair, just to indicate that we also do have the transfers to the entities of the department, which includes the Office of Health Standard Compliance. It does also include the National Health Laboratory Services, the MRC, and also the SAPRA and the CCOD, which we indicated those totals allocated. We also do have the other entities that we also transfer. And then we also find in the provinces in terms of the HR, which is the Women Resource and Training Conditional Grant of 5.5 billion. We'll also show the allocation to the provinces and also the separation of the sub-programs in terms of the HR and training grant. And the next slide, it shows the same expenditure in terms of our economic classification. And therefore, the next slides, Honorable Chair, we're going to indicate all those allocations to the provinces as I was indicating earlier. So the next slide, it shows the summary of the total conditional grant to the provinces, which is our National Tertiary Services Grant and Oncology. 15.2, and also the National Health Insurance grants for 455 million. As I said, it includes the HP contracting and the mental health, and the health facility revitalization grant, 7.1 billion. We do have the statutory HR and training component of 5.5 billion. It's made up by the two sub-components which are below, which is statutory HR to 2.5 billion and training component to 2.9 billion. We also have the district health program grant to the total of 27.9 billion. It's made up by those two sub-programs, which is comprehensive HIV and AIDS, which it does include the HIV and AIDS and also the TB to the value of 24.7 billion. And lastly is the district health component to the value of 3.2 billion. That's where we also finding, as I indicated, the community health workers, malaria and HPV programs. So that's the total of 56.3 billion. And the next slide, Chair, is the allocation to the provinces, which then the honorable members, they will see the allocation per each province. So I'm not going to read the figures in terms of each province. So the members, they will see the allocation in terms of the NTSG to the value of 15.2. The next slide, it will be the NHI, the one that we find in the HP contracting and the mental health to the value of 455 million. And the next one is in terms of the infrastructure to the value of 7.1 billion. And then the next grant in terms of allocation to the provinces, in terms of the training, just go to the next, which shows the sub-components. The first one being the HR to the value of 2.5 billion. And also in terms of the training grant to the value of 2.9 billion. And lastly, the next slide, which is our district health grant. So in terms of this 27.9, we also do have those two sub-programs. The first one, next slide, being the HIV and AIDS, where we do have the HIV and AIDS and the TB component within these conditional grants. So these are the monies that we transfer to the provinces. And lastly, in terms of district health, to the value of 3.2, that's where we're finding the community health workers, the malaria and HPV programs. That's the next slide. That's the last. Thanks. I'll hand over to the DG.
Thank you, CFO. That's where we end. We'll hand over to our minister.
No, thank you very much. I've got nothing new to add. Chairperson, I'm heading over to you for questions. Then we'll clarify everything during questions. Thank you.
Thank you, Minister. And thank you to the team of Department of Health. I'm giving over to the members for any clarity questions.
Yes, Chairperson. Chairperson.
Yes, honorable member.
Yes,
you can proceed.
Yes, thank you very much. Chairperson, first of all, I'd like to thank the department to allowing us this opportunity to come and present to us. Also to thank the minister for his intervention in terms of using acronyms, because we are still new. It's very difficult to follow, but now we are following up. Then my first question will be, to what extent does the National Department of Health control the grants when transferred to the provinces? And the second one, the 2024-25 APP was compiled before the enactment of the NHI bill. Does the enactment of the bill have any bearing on the allocation to the indirect nationally healthy insurance grant. May you please, I'm meaning to the department, may they please elaborate more that what is the status quo. Then the other one is about there is an issue which the department have alluded to about the issue of the healthy workers in terms of infrastructure. So now I wanted to find out, how is the department committed itself in order to make the people, to make the place conducive for the workers, because they also indicated that some of the places are not conducive. Allow me to touch maybe one or two. And then the other one is that since the department has adopted the model of NHI from Cuba, I wanted to find out, is the department equipped enough to achieve the goals in terms of implementation of the NHI programs? Because the thing is, one, we can, it was clear to anybody, like in our background, we accepted the NHI with our whole hands, but we wanted to check in terms of implementation, because that is the challenge. We can come up with a good idea and good things, but if there is no systems and the plans of implementation, that is the problem. And then I think the last one will be, in terms of education and skills, I saw somewhere they were indicating that they are taking people, assisting them to go whatever, to uplift their academical whatever. Since there are a lot of young people who are educated with skills, but unemployed sometimes, because some of their, practically some of the kids are doing interns, and some of them you can see that there are skills. But may the department give us details that how many people have they absorbed in these programs, the province if possible. I'll write my case. Thank you, Chairperson.
Thank you, Honorable Member.
Chairperson.
Then, yes, Honorable Member, you can proceed.
Oh, okay. I just want to check. Well, it seems to me everybody's just talking because we have raised our hands and you have not indicated in which, manner we are going to proceed one after another. But since I'm on the platform, yes, thank you very much, Chairperson. Chairperson, mine is just on a few issues in terms of, I have noted that they have indicated that the SNS will only have 2 community engagements. I want to find out, will this the only 2 be? Because then it is very few that engagement that they will have with the community. Then in terms of that 3.3 target, I just need clarity on that, because I have read in your assessment report that you are talking about the 5.5 million people that are already on ARVs against a target of 6 million. So I just want to get clarity on that, because in this presentation you refer to 3.3 million. And then also in terms of your 400 maintenance, repairs and refurbishments that you are referring to, is this against that 1.3 billion for the building constructions? And then I also noted within your reports that you make mention of the 622 million for contractors. I need clarity on which contractors that is. And then I also would like to ask, in terms of your non-communicable diseases, what programs you have in place to address these issues, because I don't see a lot of, community outreach programs that the departments have with our people in our respective communities to ensure that our people get educated in terms of these diseases. Yes, thank you, Chairperson. I have quite a number of other questions in terms of the report. Will the report be presented to us, or must I pause there?
You can first pause there, Honourable Member. We can go into another round. Honourable Briet, over to you.
Thank you, Chairperson. I would like firstly to welcome the presentation by the department and for the DDG and CFO for presenting that. I would like to start firstly with the AGSA found that the annual reports of the department were unreliable. And since then, they have deleted targets, but what else has been done to improve the reliability of this information? Then I would like to speak to the stability of leadership and the vacancy rate in terms of senior management at the department. What are we looking at? Are there a lot of vacancies? Are there not? Is there a moratorium? Can we just get clarity on that? Because I think going forward and specifically taking NHI into account, we need to look at those things. Staying with the money, I would like to speak to the NHI grant and the spending and deliverables in that. And if the department can maybe briefly, maybe that is something we need to discuss and we need to get a report on that. But how are they implementing this? I see there is a number of plans to improve primary healthcare facilities and hospitals, but how will that grant be implemented? How is that being spent, and what are the deliverables in that? And then moving forward, almost going from that, there have been a number of fires, the one at the Charlotte Maxeke Hospital, at the oncology ward, at the National Hospital in Bloemfontein, at the pediatrics ward. How will these fires impact our improvement of hospitals, and will this opportunity be taken to then upgrade these hospitals as within that plan, or how will we go forward from that? Then taking life Esidimeni into account. How has the department's policies and mental health changed to ensure that we do not have another tragedy such as that? And what is the implementation going to be thereof? Then moving further along to problems and crises. What action has been taken by the department after the SIU report on COVID-19 procurement? What will be done thereof? And then, following that, social media campaigns. The department has made mention of a number of social media campaigns that they will be running, and I know I've seen a few in terms of vaccinations, but what impact do these campaigns actually have on the ground? And then further than that, to extend to that, you mentioned a lot of misinformation about vaccines, and we're actually seeing, because of the COVID vaccine, less people having the HPV vaccine. What are your strategies to combat this, to ensure that people do get vaccinated for the multitude of diseases that we have almost been able to eradicate? My second to last question, Chairperson, would be malaria and our addressing of malaria. How is climate change and this extreme weather we've been having, where it's been extreme heat, extreme floods, that of course being, a very good environment for the mosquito to actually breed in. How has climate change affected malaria, and what is being done to address this? And lastly, I welcome the fact that we are looking at digitizing patient records and having electronic patient record development. But I think it be prudent to know what the budget is for said digitization of patient records, I see it was a phased implementing. What is the time frame and what phases will there be in this implementation? Because as we've seen with other departments, when we speak about digitizing and doing electronics and ICT, it has been marred by problems and issues and money spent and nothing been delivered. Chairperson, I will leave it at that. Thank you.
Thank you, Honorable Member. Honorable Kiwa, over to you.
Thank you so much, Chairperson, and greetings to the Minister and Deputy Minister, the team, and all the colleagues that are on the platform. These are my questions, Minister and your team. On Program 2, on the SMS program, that's my assumption is that it's facilitated by an outsourced company. I want to ask what company this is, and second to that, if the department has a plan on building internal capacity to carry out such functions, because I think it is very short-sighted to constantly outsource when we are of the idea or see that a program of some sort will be held in the long-standing. It's unsustainable to keep outsourcing when there is a possibility of building capacity. And also in regards to that, we must start acknowledging the dangers of outsourcing healthcare services, especially following the judgment of the Life is Dimini inquest. It must bring us to the realization that building capacity, state capacity, is very pivotal to building a sustainable healthcare system. And that's not the case or the direction that we are taking currently, especially with the NHI. It is a growing phenomenon that the government is basically washing its hands about building state capacity and ensuring that the public sector is catered for and that the government is able to carry out its own duties to that effect. And on program number 2, so I'm citing the SMS program just as a leeway for the minister and his team to be able to get into this thing of building state capacity in the department in particular. And on program 1, and I mean, this is across the board on all the programs, there is a reduction of targets as opposed to outcomes of the previous year. And in some cases, there's just a general reduction of targets. And this is a trend, I think, even when Deputy Minister Patla was still minister, it's something that we appraised, or we rather raised with him as well, that it's an ongoing trend that the department keeps reducing its own targets. And there is no explanation on why the department keeps reducing its targets. But this one is particularly concerning because you reached certain outcomes in the previous year, as seen in the performance appraisal, but you then reduce the target of the incoming year. An example, for example, is the social media health promotion messages by the department. Last year, you did 399 social media health promotion messages, but the target for 2024-2025 is 200. What is the reasoning behind these reductions? And the removal of targets as well. What informs the department deciding, okay, we'll remove this indicator and then, or we'll replace it with something else, or we'll introduce another indicator, or just remove it completely, and the reduction of targets? Is it the issue of budgets? If it is that to effect, please appraise us in detail, so we know exactly why this target was removed or why this target was reduced, despite the fact that in the previous year, the department had actually reached and even surpassed its target. And on program number 4, on the community outreach program target, 14 million. Is it inclusive of tracing of patients and clients that are lost? I'm asking this because that was one of the targets in the previous year, and I see it is not reflected in this particular year. And please appraise us on this particular thing of tracing patients, because I think it was a very important indicator and target that the department needs to stick on by, because it forms part and parcel of prevention and education and the basis of primary health care, right? Because some patients come into the hospital get their medication. Umuntu masizwa ngathi usewumqamane kancane bese ayeke medication angasayi esibhedlela. But that doesn't mean that they do not need medical intervention. And because this person is already on the files of the department, they are your patient already. And the responsibility is also on the department to ensure that it is able to ensure that their patients and their clients are able to comply with medication. And if there's mental health issues that become a problem in that process of complying with medication and taking medication consistently, then the department is in the know and is able to trace their own patients. And second to that, there could be other issues that arise or that inform the decision to no longer go to a hospital to collect medication or to go for checkups and stuff like that. And because this indicator is removed, it then raises concern, because then what then does the department measure its performance in relation to this? Because it affects other programs as well, like for instance the HIV program, which was able to bring forth these NGO interventions that you guys did with the teen clubs, with other NGOs and stuff like that. Those are important programs, and it means it then affects even those kinds of interventions by civil society as well. And on program number 5, please kindly appraise us with the details of these planned constructions and revitalization of facilities, so that members of this portfolio committee are equipped with adequate information in the case of intending to do oversight. And second to this, do these targets include that of the year 2023? I'm asking this because the numbers are almost similar with the outcomes of 2023. And if there is some similarity, please just clarify it for us with the details of these facilities of both 2023 that were revitalized and the new constructions, and also those of 2024, 2025, to avoid repetitive reporting. Ningasikhathi, Minister, if there's a hospital you were fixing in 2023, but nisayilungisa namanje, but now it's presented as a new target, I think that would be misleading the committee on the targets that the department has set for itself. And last 2 questions. I want to find out how the department has managed to, or if the department has managed to lower medical legal claims, particularly concerning obstetric violence. Nama case of maternity ward wabantwana, right? And which facility is currently the highest, and what the plan of the department is about intervention. And also in relation to this, Minister, there is this, I don't know if it's, and the minister will clarify the committee as well, where, and I'm speaking particularly to cases where umama ezala esibhedlela and then kube umntwana alimaleke, but kungabi into egqama in the immediate, and then 4 or 5 years along the line, then sesiyabona umntwana ulimele mayezalwa, and then when they do analyses and all those things, they're like, no, umntwana ulimele mayezalwa. But the period of 3 years has lapsed. How does the department ensure that mothers in particular are able to be covered in cases such as these? Because they keep coming up as grievances by the public to our offices. How do we assist them, Minister? Because I'm a lawyer, they can't go over it sometimes, and it becomes a problem, because then it means that these particular cases, all these kids and their mothers don't get justice, despite the fact that negligence did happen in the hospital. And lastly, Minister, in relation to community healthcare workers, so it's a service that you are constantly using in all provinces for in-house visits, for the tracing of lost patients or patients who don't come back to the institutions and facilities. When will they all be absorbed permanently? Because it's a service that we continuously use. I think it's also a tad bit unfair to keep these employees on 6-month, 3-month contracts when we know that they should be fully absorbed in the department's system. Please appraise us on if there is a plan to do this, and over how long will it take to ensure that community healthcare workers are fully absorbed and are sustained and maintained in the system as well. Thank you so much, Chairperson.
Thank you, Honourable Member. Honourable members, can we talk through the chair and not addressing the Minister directly? Honourable Du Plessis, you can proceed.
Thank you very much, Chair. I would like to say I appreciate large parts of the presentation, including decentralization, but I would like to go into details a bit later. But I want to start off with, it is always heartening to see the plan. However, I'm always concerned about the implementation and the on-the-ground feel. I'd like to start with the idea of a clean audit. Obviously, it's something that has to be supported, but I would like to find out why in most provinces do we not have access to I&E reports, income and expense reports, neither is there a breakdown of line items. And the reason why I'm asking this is more often than not, we get an X amount budgeted for, let's say, a generator, but then X minus 100,000 Rand gets spent on the generator, and then the generator on the ground is a substandard generator. So I would want us to look into that to improve our oversight capabilities. Then when we start talking about provincial support or the need for provincial support on a financial level to ensure clean audits, we cannot just keep on giving money without M&E or accountability measures. And when I speak about accountability measures, we do need to have an historic view of where the money has gone and when it has not been spent on the for the best of the people on the ground. And here there are a few examples of, when I've done oversight in provincial clinics, that the provincial clinics have been asking for upgrades for almost 20 years. It's been budgeted for, however, things have not gone through to those provincial clinics. So what are we putting in place to ensure that we have a historic view, what needs to be addressed, and how can we hold people to account to ensure that they do not do the same things going forward? The next part is also touching on medical legal issues. This is a two-pronged question. On the one side, it does seem like the external lawyers that we do hire for medical to process and assist us with medical legal claims often squash very relevant medical legal claims, and there are people left without actually having their claims addressed. There's a very upsetting example that happened in Penang, where the mother went in pregnant with twins, but came out with only one baby.
Chairperson.
Yes, Honourable Member.
Chairperson, there is something happening in the background, and so we can't hear the questions. There is a meeting or some talk there at the background. I don't know whether it's on the member side or what, but please, can it be muted, because we are missing a lot on the questions.
Thank you, Minister. Honourable Member, make sure that you are out of that.
Is this better?
Yes, much better,
Right.
Honourable Member. You can proceed.
Unfortunately, I'm in a public space, so I just needed to bring the microphone closer. Thank you very much, Honourable Minister, Honourable Chair, for correcting that. So with regards to medical legal claims, there's one lady that went in with twins. She unfortunately only came home with one child. All of those documentation, I'll resubmit a question about that. But the point is, it was one of the cases that was squashed. I'm also concerned that our external law firms are often working on commission based on how many of the medical legal cases are squashed, or not squashed, but sort of, for lack of a better word. So I would like us to look into that because it is about patient dignity and ensuring South Africans feel heard, but also looked after when there have been real problems. Could we get additional information on, for example, what has been achieved with regards to MDR treatment within TB, as well as as TB. The reason being is I do know that as a country, we have improved our TB treatment massively. But I'm also concerned about when we look at MDR, how many residents are aware of the fact that when one has MDR and you infect another person, that person then gets MDR as well, which is multiple drug resistant TB, and then the treatment increases, and then the burden of disease increases as well for us as a health system. The additional part that I'd also like to address is mental health. When we start looking at psychiatric hospitals throughout South Africa, they are not necessarily addressing the issue of from neurodivergence to all the way to, let's say, normal anxiety, well, not normal, but anxiety and depressive disorders. We are in the top 10 countries in the world with regards to suicide rates, which is an alarming statistic if one looks into that. When I start talking about mental health, I also would like to address the issue of internal mental health for our healthcare workers. If our healthcare workers feel that it is not a stigma within the system of healthcare, they will be able to address patients with healthcare issues, neurodivergence issues, et cetera, with more dignity and care. And I'd like to link that with, and I really would like to say I'm quite excited about the focus on household visits. But when we are looking at not just giving caregiver education on non-communicable diseases or anything of the, but that we also look at mental health education, because for most South Africans, mental health is still a stigma, and it is something that we do need to look into. Then we haven't seen anything with regards to EMS other than the training on EMS or something like that. However, EMS on a national level seems to be a little bit of a crisis. We have patients waiting for hours. I have personally dealt with an issue where in a meeting over 2-3 hours, the patient passed as they were waiting for the ambulance. The reason for that was the ambulance was meant to go into a red zone. And as just to explain red zones, so those are dangerous areas where SAPS needs to go with the ambulances. However, SAPS just did not show up with the ambulance. And what are we doing to improve transversal relationships and a whole of society approach to support healthcare? Then I am almost done, I promise. With regards to NHI, we need to look at our systems from our e-health. One of the things I'd like a look at is we have in various provinces been paying for e-health or for systems, EMR systems, since about 2009, without an actual implementation of these incredibly important systems, because it assists from literally patient history all the way through to reminders of when a patient needs to go back to the hospital, as you are all aware. So what are we doing to hold people to account who have been getting a large amount of the budget to implement EMR, but there is no system to speak of? Then with regards to hospital infrastructure, are we starting to look into moving that competency towards the health and wellness departments within our provinces, away from DID, Departments of Infrastructure Development, on provincial levels, because it is one of the biggest issues that I've found, again, when I do oversight, especially in PHC, is that small things are not dealt with. And as you are aware, and I think it was mentioned as well, that maintenance is cheaper than fixing a big crisis. So are we looking at decentralized, or not decentralized, but we are, and I think there was a solution given, but we do need to look more intensely into that. And an example of success there would be Telemuerani, where the new CEO ensured that the DID officials on site were held accountable for every single project that needed to happen. Then with regards to the food safety regulations, could we also include the budget items that have gone, I'm not sure if all provinces have it. I know that many of them have child feeding schemes. And there again, an X amount is budgeted, but on the ground, our children get, let's say 200 Rand was budgeted, they get a food equivalent on 20 Rand. Again, there are many cases that prove this. And we are then stuck with malnourishment and also then the additional burden of disease of what happens with stunted growth. And then lastly, with regard to nursing, I have spoken about it to a certain extent, is that when we look after our nurses, and I mean not just look after in the sense of a financial support, but we start looking into how are we supporting them on a mental place? How are we supporting them on education? And an example here would be, I have asked multiple people in emergency areas, what is triage, or where do you do your triage? And my response is, or the response I get is, we do not know what triage is or what is triage, which is massively concerning, especially if we're linking it with the ideal clinic space. The other thing that, or the additional thing that I'd like to see us do is not just the training of new nurses, but also the support of nurses within the system, because we are seeing an increase of nurses leaving public healthcare to private healthcare for a lower salary, but finding that the space or the system in which they are functioning is easier for them to do their work. Then with regards to, apologies, there was just one last point. The PPPs, there are various instances where PPPs have worked incredibly well. For example, the Stanley Daphne Oncology Center in Johannesburg. There are other instances of this, and are we looking at increasing PPPs so that the private sector, and especially when we are starting to look at universal access, supports the system of healthcare within South Africa? Thank you very much, Chair, for the indulgence.
Thank you, honourable members. Honourable Minister, over to you and your team.
Thank you very much, Chairperson. I think the questions will be answered systematically because they fall within different problems.
Chairperson, sorry to interrupt. Honourable Chairperson, you skipped me.
Yeah, I saw that.
Oh, yeah, sorry. Sorry, Honourable Adriansa, because it's only GN that is on the platform.
Sorry, John.
Yeah.
Yes.
So, Honourable,
Sorry,
you can proceed. Yeah.
Thank you, Honourable Chairperson. I have a couple of points that wasn't raised as yet, and I would like to do it now. I have one clarification question. I'll go to that, but I see that all the systems heavily rely on electronic medical records, and I firmly believe that's the way to go, because that is certainly the main issue here, because paper records get lost and it's not universal and national. But in late June, the South African National Health Laboratory Services, NHLS, was hacked. And that nearly caused the paralysis of the public healthcare system, as no tests were available. Now that was a massive situation, and some procedures couldn't take place, and the surgeons had to operate blind because of blood platelets, etc., not being available. So I want us taken also in consideration the sensitivity of the information and the POPI Act and being compliant, that we make sure that this information is secure and very protected, since this has been hacked, the same system more or less has been hacked. And then I believe, as I've noticed before, the complaints regarding capturing these medical records, because the people don't really know how to do it. I don't think they've been capacitated to do so. So on ground level, we need a training system for the people working in, for instance, in the clinics in basic care, how to do this so that it can interlink. Then as we speak about clinics, we have in certain areas people sitting outside the clinics while there is waste burning and polluting the air, and they're inhaling that. So it creates a double health jeopardy. Then also all the other stuff was basically covered. I just want to ask the compensation of employees. I want a clarification on this. You said that the reduction of the 15.9 million from a baseline of 710.17 million it just meant it didn't affect the appointment of employees. But why then is it that in hospitals the doctors and the interns have to work double shifts, etc., if it didn't affect that? And how many doctors that have just completed their final years are not being employed at our state hospitals as interns? Thank you. That's it from me.
Thank you, Honourable Member. Honourable Minister, over to you.
Thank you very much, Chair. I was saying, because the questions are in various programs, we will try to allow officials in those programs to start first, but let me give it to the DG to conduct as to who will answer what. Then we'll come at the end, who will answer what question, then the DG will come in, and then the Deputy Minister, and then myself, I'll summarize. Thank you.
Thank you, Minister. Over to the DG.
Chair and Honourable Minister, and thanks to the members for elaborate questions. We really appreciate that they actually followed the presentation. We're going to divide the questions. We'll first start with the Chief Finance Officer, the CFO, to deal with there's few questions like the control and monitoring of conditional grants to provinces. He will also touch on the issue of the terms of jet, how we're going to be dealing with that, and any other relevant question. When he's done, I'd request, I hope Professor Crisp is still on the call. Professor Crisp will deal with all the NHI-related questions, NHI-related questions that include the CCMD. The targets were done before the ascending of the bill into an and then I'll also just to touch on the issue of the SIU procurement issues, since he also sits in the Health Sector Anti-Corruption Forum on the work that is done there. He will then also, from what I'm seeing here, I would like you also, Prof, I know you've been involved together with Jeanette on the issue of their absorption, as it was raised. If you can deal with that one, I will deal with the infrastructure questions, and then Jeanette. There's an issue on some of the indicators, including the issue on malaria, the effect of why we changed the indicator from people traced to just the household visits, and how do we account for that? And then you will deal with that one, and then I will deal others that would be left. So may I then request the CFO to start?
Thanks, DG. I will start on the questions on the COE. The decrease in the compensation of employees, as indicated, it's only for the National Department of Health. So it does not include the allocation in the provinces. Honorable Chair, maybe just to also indicate that the total budget allocation for the sector, including the conditional grant, it's around 259 billion. So the other allocation in terms of the COE in the provinces, it will include their voted funds. And that 259, it does include the 56 billion conditional grant, which I was presenting earlier. Also, while on the medical legal claims, only just to indicate in terms of the total figures, but the colleagues, they will indicate in terms of the management of medical legal. The total balance for financial year 2021 to 2022, it was 82.6 billion, and it has reduced to 77 billion in 2022-2023 financial year. And we are still waiting for the audit outcomes in terms of 23-24, which is the current audit, which we are busy finalizing with the AG. The other question in terms of the monitoring of the conditional grants. So what we monitor as the national department, it will be the 56 billion conditional grant that we allocate to the provinces, as we have indicated in terms of doing the monitoring. We do have the CFO's forum where we also discuss the spending and compliance in terms of the spending on the conditional grants. And we also do have the conditional grant managers at the national department, which they also do the monitoring on the conditional grants. So the DG, he does approve the business plans together with the HODs in terms of each conditional grant for implementation, which it does also include the annual procurement plans specifically for those conditional grants, so that when we do the monitoring in terms of the expenditure and compliance, so those are some of the reports that we therefore consider in terms of doing that monitoring. The NHI grant in terms of the spending within the program too, we also did indicate the earmarked funding that the program they have in terms of implementing different sub-programs, which Prof, he will then go in details. On the NHI grant that we have, that goes to the provinces of 455 million, it only includes the HP contracting, which will contract the healthcare professionals to assist the provinces, and also the mental health program. So I think those are the questions, teaching, that I had to cover. Thank you.
Much, CFO. Professor Chris?
Yeah, thanks very much, Gigi, and thank you very much to honourable members for the questions. You didn't see me because I borrowed somebody's laptop because mine's giving trouble this morning, but I am here. So let me start with the NHI questions. The first question that was asked was to do with whether the timing of the approval of the budget and the preparations in the APP for this year, which preceded the signing of the NHI Act, has impacted. So we're not actually implementing the NHI yet. The Act has been signed, but none of the clauses has been brought into law yet. And I think the honourable member is absolutely right. We will only now in this budget cycle, which is just commencing now, engage with which actual activities of the NHI funding may be brought into effect in the next financial year. So all the matters that are on the budget for this year are to do with health system strengthening and preparing the capacity of the national department, that's the branch that I'm running, to support the implementation of the NHI. So that is quite correct. The question of whether we are equipped to implement the NHI, the National Health Insurance Fund will be run by a Schedule 3A entity, and that's in Section 9 of the Act. And that will still have to be established in the coming 3 years, and that's provided for in the Act in the transitional provisions. So in terms of are we ready, are we able, do we have the capacity to get it going? Yes, we do. Do we have capacity to run the whole NHI now? No, clearly not, because it is not the entity is not established yet, and the shifting of the funds will only commence when that's in place. So, yeah, I'm sure during this term, the honourable members will see a lot of changes in the way things are managing. The CFO mentioned about the conditional grants. So just also, it's sometimes a bit confusing. There's the largest part of what is labelled NHI in the presentation that the honourable members saw this morning and in the budget is about infrastructure. So it's more system strengthening to ensure that clinics in the public sector and health centres in the public sector are improved and are able to get their quality up to standard in terms of what's required for certification to become accredited providers in the fund. It's not so much directly, it's not spending on patient care on behalf of patients in the NHI, because there are mechanisms through the provincial equitable shares paying for those services at the moment. I know it's quite a bit to get one's head around in the beginning, but these things will begin to change now that the act is signed. There were other questions about in the NHI and the importance of the digital system. So several members raised questions about this. So what we are busy building at the moment is what we call the transversal system, so that any provider, whether they're public or private, will be able to see a patient, and that patient will be able to move between the providers. So between GPs and public sector clinics, between the primary healthcare GPs and public clinics and the hospitals, and to be able to move either on work or on holiday, or as people move around, they will have their electronic record accessible, that the next practitioner who looks after them will be able to add to that record. The health systems are complex, so you don't have to have everything running on absolutely the same system, but they must be interoperable. So a lot of emphasis up to now has been focused on making sure that whoever is installing, whether it's a hospital information system, a patient information system in a general practice or elsewhere, are interoperable, so that the data can be exchanged as we implement this common electronic medical record. We will happily make a separate presentation on this in due course. The next issues that the DG asked me to talk about is all the fraud and corruption and the medical legal claims. So as DG mentioned, I'm a representative of the department on the Health Sector Anti-Corruption Forum, which was established by the President. And the President gets reports directly from that forum, which comprises public sector and private sector role players. There are a whole range of issues that are before that forum at the moment, mostly in the public sector, but also from the private sector. There's a lot of fraud in the private sector, as well as the corruption that's reported in the public sector. But the specific focus at the moment for today's request was on what's happened with the SIU PPP corruption. And the SIU reported, because they chair that forum, they reported on a whole lot of activities that are ready for prosecution, and which will now either have already gone to or will go to the prosecutor for action to be taken on them. So it's definitely not forgotten, and there are several cases that are now at that point. Regarding the medical legal cases, there's a separate discussion in the Anti-Corruption Forum, but there's also a big activity in the National Department together with provinces to better monitor where the cases are being lodged and who's lodging them, and the issues that were raised by the honourable members on patients that are awarded amounts and then that money never trickles down to the patient. The reports are actually frightening. So there was this proclamation, I think it's 74, I can confirm the number, Proclamation 74 of 2022, which the Departments of Health actually requested SIU to get from the President to investigate the whole medical legal cases situation. And the number of fraudulent activities that are going on, led by legal professionals who are claiming for patients. Sometimes the patients don't exist, sometimes the conditions didn't exist, sometimes they claim in more than one court for the same patient. Often they might win a claim by colluding with the state attorney's office and with others, and amounts get awarded. And then I think it was the Honorable Chua who mentioned that then the mother doesn't get the money for the child. These are all being followed up, and at the meeting on the 28th of June, there was a very comprehensive report presented to the Anti-Corruption Forum, and I saw that on the SIU's website, one can get quite a lot of these details as well. So it's an ongoing battle. It's a matter for both public and private sectors to deal with, and there is now a forum that is actively engaged in this. I think there was one other question that was asked of me. Yes, that's to do with the CCMDD, if I understood, and outsourcing. So the challenge with the chronic medicines, the centralized chronic medicines distribution, is that it was developed as a small project using donor funding, and it has outstripped its what was initially the small project, and it's become a very big program. We are systematically, and the CFO mentioned this, we are systematically moving more money into the program, but we were not given authority to create posts, full-time posts for managing this program. So it is absolutely true that the staff, all bar one, are paid for not by public servants and not through the public service money. It's not outsourced in the sense of us procuring from an agent, but they are all paid for by donor agents. And we share the concern that this makes us vulnerable, and it is something that we continue to raise. And hopefully in the coming year, we'll be able to do something to get more permanent posts for supporting the CCMDD program. Yeah, I'll stop there. Thanks, DG.
Prof, you didn't touch on the electronic medical health record, the timeframes and all of that, and also.
Oh, sorry. Yeah, sorry, I didn't mention that. So at the moment, we are busy. The portable electronic medical record that we want to have accessible to all 60 million plus of us in the country. Phase one, what's called the minimum viable product, which now goes for testing before it gets implemented, has been completed. It's busy with field testing at the moment. The initial focus is on the HIV and TB portions of that record, because we have a lot of parallel old systems that are legacy systems not doing what we need them to do. The subsequent phases are now being scoped out as well. So what will happen is now, between this testing, which is going on in the Free State at the moment, we anticipate that by November this year, there will be a wider implementation. But the honourable member who raised this was quite right, that if you don't train people, it's all very well to have a new program or a new record, even if it is able to, relatively straightforward to access it on the internet or elsewhere. It is, people do need to be trained. We also are well aware of what happened in the National Health Laboratory Service. In fact, it happened in the mining industry today. They were hacked yesterday. And we know that hackers are very busy with getting into systems with their ransomware. So all I can say is that we do regular penetration testing at least once a month. It's random tested, where we try to, the people who are designated to try and hack into our systems do it on a random basis. And so far, on the systems that we are working with from the National Department for the NHI, we have not had any breaches yet. But we have to remain vigilant. People are getting cleverer and cleverer and hacking into these systems. So we are making progress, but there's no one specific budget, because it's in the provinces have their portions of budget, and there are parts of the program that are funded from within the National Department, either from our regular allocated budget or from the conditional grants. And we would have to try and bring all those bits together to describe what is actually being spent on the various components of the digital systems. Thanks, DG.
Thank you very much, Prof. I forgot to request Reverend Morewane. There's some specific questions on HIV, PB, and also maternal, child, and women's health. Reverend Morewane.
Yeah, no, thank you very much, DG. And once again, good morning to the Honorable Chair. Good morning to members, but most importantly, good morning to the Minister and Deputy Minister and my colleagues. Chair, there were three questions which I'll respond to. One was raised by the Honorable Aris regarding the total number of HIV/AIDS patients on treatment, and there was also a mentioning of the 3 million. Just want to clarify that the 3 million number that's appearing on the screen is actually the number of those that will move from collecting treatment in our facilities to collecting treatment through what we call decentralized models of care, which will be on the 3 multi-month dispensing approach, which means they'll then get a treatment that will last them for 3 months while they are at the place and at the place of work and also even in their communities without them having to come to the facilities. So that's why that number appeared. The question from the Honorable Chirwa about the reduction of maternal mortality, maternal child health adverse events issues. Just to assure honorable members that the ministerial advisory committees on both the maternal and child health are active and they meet quite regularly and they give us reports on what is wrong. And on the basis of that, we have then developed modules for which clinicians are able to go through Knowledge Hub to get trained and they get certificated as being competent to manage the complexities and even routine issues around maternal, child, and neonatal spaces. So we have been training many clinicians, in some of them, even from private sector, free to join, because our people may start at the private sector first. And when they then progress in their complications with the shortage of money, they will then come to the public sector. So we have not been limiting, but the first cohort was mainly from the public sector, and that has been going on very well. We've also realizing that we need to also update our colleagues. We have updated and revised 3 set of guidelines, and these which have been approved by the National Health Council. They are focusing on maternal health and child health and neonatal care. So those guidelines are actually part of the modules that are made available for training for all clinicians. And with regard to child health, we've introduced a new set of vaccines, upgrading some, improving others, and also, those that were in the system from long ago. From January this year, we've been introducing the new vaccines that are also meant to ensure that we protect our children, particularly from the vaccine-preventable diseases. And with regards to the questions raised by the Honorable WC, there was a question about, I just wanted to say, how do we inform the general public about the MDR? Just to say generally, we've got a system of advocacy, civil society engagement, communication with people. So what we have done, we have gone to the National Strategic Plan for HIV/AIDS and STI and TB and annexed out the specific areas on TB because we didn't want it to get hidden in there. So on the basis of that, we then developed what we call TB recovery plan. And this TB recovery plan was endorsed at the level of the South African National AIDS Council. In fact, as a matter of fact, on Monday and Tuesday, the civil society has been meeting to specifically, hone on these matters that are on the recovery plan. They met on Monday, and then we joined them on Tuesday to together agree fully that we are going to jointly be advocating for the implementation of the recovery plan. And why do I raise it? It's because in that recovery plan, all key challenges around TB are raised quite intentionally. And one of the pillars of that is about community engagement and social and behavioral change regarding our communities. And the civil society is committed to take a leadership. And in that space in particular, the PLHIV and those people that are either survivors of TB or what we call TB champions or ambassadors are going to be running with that. So in that regard, I can confidently say our education is going on. Hence, in our planning, the MDR continues to be part of the annual performance plan to make sure that it doesn't fall by the wayside. And the targets, as they can be seen from the presentation, actually coming closer to where we really want to be with regard to the drug sensitive TB. So DG, I thought that those were the ones. I'm not sure if I missed any, but these are the ones that I've recorded. And let me stop here, DG, and hand over to you. Thanks very much, DG.
Thank you very much, Reverend. Jeanette, please come in for PhD-related questions. There's one that talks. There's one that talks on CD programs, then on CHWs, and the IDR clinic. Thank you.
Thanks, DG. Honorable Chair, I'll start with a question that was asked about why do we only have 2 community outreach, a target of 2 community outreaches in the APP. Just to say that we are guided by a framework that we received from the Department of Planning, Monitoring and Evaluation in the Presidency. And what they ask us is that we must have a good balance between what is strategic and what are the operational issues that we put in. And usually we are guided by this issue of what is strategic is, what are we doing that is new? And once we have over some time, maybe 2 or 3 years, institutionalized a certain intervention, it is then advised that we remove it from the APP because it's now become operational and putting some new strategic intervention that will take the department on another loop forward. So these 2 community outreaches are seen to be 2 huge MBISOs with specific communities, and these will be led by the minister and the deputy minister. But over and above that, we have a number of community outreach programs throughout the year. There is, for example, what we call the expanded screening program, expanded community-based screening program that is usually officiated by either the minister or the deputy minister, where we go into the districts. And that's a program that we schedule with the provinces, that we pick a particular district in the province. We have the communities there. The minister or the deputy minister accompanies us on home visits with the community health workers, and then also look at the work that our traditional health practitioners are doing in the area of health education and referral to the clinics. That link with traditional health practitioners was highlighted in the instance of cholera in the Hammanskraal area last year. And that link is important to locate problems in communities early, quickly, and to implement the right remedies for certain environmental health problems in the communities. So we have those outreaches, we have clinic open days. The minister usually accompanies us to either a well-performing clinic or a poorly performing clinic, where we have the community service by that clinic come to interact with the minister, and for minister also to provide information and get information from the clinic committees, who are the representatives of those communities at the clinic. And we usually get compliments at these sessions, but we also get the complaints, and then we have to address those complaints and report back to the minister. In terms of live esidimeni, after the recommendations were supplied by the then Ombud, the National Health Department had to look at whether our licensing regulations for the institutions meets all the norms and standards. And we did that through setting up a multidisciplinary task team. And they developed new guidelines for the licensing of residential and daycare for people with mental and intellectual disabilities. And we moved to guidelines because that would be quicker to get approved so that we could effect the changes. And this was back in 2017, so that we could effect the changes within these residential and daycare facilities. We also then developed the regulations, and those regulations were actually approved by the National Health Council now, April, and the process of promulgation is almost complete. And so we now use those guidelines, and we'll soon be using the regulations to do the regular inspections and make sure that these facilities meet the standards that they have to meet. Just the next one was on malaria and how climate change affects our malaria program and then the incidence of malaria in the country. Yes, climate change in terms of the extreme heat and with flooding that leaves dams standing around really increased the existence of a conducive environment for the vector to multiply and cause problems in this area. And so we make sure that we do sensitivity tests to make sure that the chemicals we use for spraying, because in South Africa we have found that the spraying of the areas where vectors breed is still the most effective way of combating malaria. So we do regular sensitivity tests, making sure that the chemicals that we use, the vectors, are sensitive to that. And another thing that we did that actually showed great success in KZN, and this is in the light of climate change, is previously we used to have seasonal spraying. But we started in KZN and started with spraying right through the year and not doing seasonal spraying. And we're really encouraging the other two provinces with problems with malaria, that is in Mpumalanga and Limpopo, to do the same, to move to spraying right through the year instead of just seasonal spraying. The one about the absorption of the community health workers, firstly, where we are at now is to update a business case that we did in 2017 to update it with 2024 figures to make sure what is the ask that we have of Treasury. If we're going to, Honorable Chair, we will not be talking about absorption, and I'll explain why in a minute. But just to say, if we look at formal employment of community health workers, what is the budget that we need to do that? So we updating the business case, and once that is approved in the Tech NHC and the NHC, we will then start the engagement with Treasury to see if we can have more resources. Now, to move to the area of absorption, we cannot absorb anyone into public service. Individuals will have to be formally employed by using the public service prescripts. And that is a post that must be advertised and applied for, and then people will be appointed. We also, in the National Bargaining Council, engaging organized labor with the conditions around this issue of how do we engage community health workers formally. But I do, Honorable Chair, want to assure the committee that we do not have short-term contracts for community health workers anymore. We have greatly improved the stipend that community health workers are receiving. We have contracts for at least a year, and there are talks to see how we can, while we try to find the resources to engage community health workers formally, how we can improve the current contracting conditions and make it maybe even longer than a year. The other issue that I want to mention, Honorable Chair, because the members may be aware of that, is that community health workers who have been long in the system and who do not have matric are concerned about what is going to happen to them when we start talking formal employment, and there are already prescripts within the current policy that is being updated that community health workers must at least have matric. We are not going to abandon anyone, Chairperson, who have assisted us over many years with this program and who have done good work. there will definitely be conditions to make sure we remain with those community health workers who do not have matric, but who have experience and have served us for a long time. So this issue about matric will be phased in, and it's not something that will be abruptly started so that we leave others who do not have matric wanting in the process. The question and actually strong comment about what are we doing about neurodivergence and that it is neglected, and then also the issue of maybe people with lower levels anxiety slipping through cracks, and with the danger that they can later on develop a serious mental illness if lower levels of anxiety are not addressed. In our work with the education department, we know that the issue of neurodivergence is something that they attend to through the school psychology services. They are also training teachers to recognize symptoms, so that because it's important to diagnose neurodivergence in children and to be able to then refer the kids and assist them with learning programs that are tailored to their specific needs. For lower levels of anxiety, again, that's where our community health workers play a big role, because those lower levels of anxiety are almost always caused by social conditions. Community health workers are trained to in conversations, recognize that, and also refer people to social workers for help and so on. And in addition, I think the CFO spoke about it, there is a special grant that we use to train our health professionals at primary healthcare level to deal better with mental health. And that's also picking up, vague symptoms of mental health early, so that people are assisted before these develop into more serious conditions. I'm just looking at, I think, yes, DG, I've covered the points that were asked pertaining to primary health care.
Thank you very much, Jeanette. Let me take a few before I hand over to my Honorable Deputy Minister. There was an issue on the doctors and interns in terms of the appointment. The data that we have from PESAL, that from January this year, we appointed 2,056 medical interns and 2,168 community service medical officers. And then we also then appointed, if I look at the numbers, those that I would say were immediately post community service that were appointed in the whole country were as medical officer grade 1 were 1,955. And then there were others that obviously were appointed from outside because they came in at a higher grades of medical officer. There were a medical officer grade 2 is 167, a medical officer grade 3 is 242. So in total, from January 2024, we've been able to appoint 6,588 doctors, which is inclusive of interns, community service medical officers, and grade 1, grade 2, and grade 3 medical officers. And I would like to also just thank our Deputy Minister, who was the Minister then, for actually fighting for us with Treasury so that we got some additional 3.7 billion to assist us so that we appoint these doctors. The next one is on infrastructure. There was a request from Honorable Chirwa on the names of the facility. These names are readily available because either from the provinces, when they submit a business plan for the direct grant, the health facility revitalization grant, they do put the facilities they are going to maintain or revitalize. So we have for all the country, because otherwise we don't sign the business plan. We also have for the indirect grant. So this information is available. There might be those that will appear in the previous year because some of the work is multi-year work. For example, I will make for the indirect grant here at National, the Limpopo Academic will appear for a number of years because it's a greenfield project and it's going to take some years. Siloam as well will appear, and it because a multi-year project, it will not only be limited to 1 year. That applies also to some in the provinces, but that information is readily available for the honorable members. And then the second one was the issue of the reliance on Department of Public Works or Department of Infrastructure Development by the provinces. This is one area that is very difficult because provinces, as we are, they are semi-independent. Actually, health is a concurrent function in terms of Schedule 4 of the Constitution. So some provinces still use this, but I will make an example. For example, in Gauteng, during the fire at Charlotte Maxeke, the then Premier Makura, happy in terms of how the work was being done. And in consultation with the minister then, Premier Makura decided to remove Charlotte Maxeke Hospital from Department of Infrastructure Development and gave it directly to health so that it could work with us. So it's up to the province, and for him to do that, he actually had to gazette it in the provincial gazette that he is doing that. So it's an issue that really provinces are working on, but I am aware that some provinces actually, because of the frustration, have actually appointed the there's a Development Bank of South Africa, IDT, which is Independent Development Trust, and KUHA to do work on their behalf. We also, as National, through our indirect grant, we work with these three are actually the agencies of the Department of Public Works to actually implement the infrastructure. Now, there was a question on the issue of the fires, the recent fires, one at Charlotte Maxeke, there was one at we're still waiting for the reports from the two hospitals. I did personally visit Dr. George Mkari with the team, and we've asked, there are two parallel investigations because we did lose a life there. So we asked our health ombudsperson to do an independent investigation, and I'm told they are already on the ground because the CO did tell me. But the police also are doing that, so we get into the detail of what actually happened in terms of that fire. But generally, in terms of occupational health and safety, all the facilities that we work with are supposed to be certified fire compliant by the municipalities. And we always, this area is one area that is a standard item even in the National Health Council, where our HODs are reminded of the important issues around fire compliance of the buildings, so that we don't actually experience what we are currently. The other honorable member raised an issue of the absence of the emergency medical services. It is covered in slide 19. And what we do as National here, we actually audit provinces for compliance with the regulations that relate to standards for EMS. And part of these standards is about the waiting times and the other issues. So we do evaluate what's happening in the provinces, but we are aware, and it's a matter that has been in a number of the National Health Council meetings in terms of the availability of cars, the personnel, the topography in terms of the roads. For example, in the Northern Cape, because of the distances, the cars, they get tired very early. Imagine if you have to take a patient from Dr. Harry Surki in Uppington to Kimberley and vice versa. So those are the issues that we are aware of, and we are trying our best to ensure that we've got enough personnel and we've got enough cars. But what we are working on now is also working through our Emergency Operations Center. We actually want to put up a system, an electronic system, where we are able to actually have a better overview of the functioning of emergency medical services throughout the country, using a particular system that Western Cape has actually implemented. We want to centralize it for all the provinces. I think I've covered most with the colleagues. There was a question on PPPs. We are involved. Currently, we've got 2 PPPs that have been approved by National Treasury. That the team is now working on together with DBSA. That's for Chris Hani Baragwanath Hospital, and the one for King Edward, the 8th hospital. Well, I'm told it's now Victoria Mtsange Hospital. Those 2. And we are still pushing that if they can assist us with the others, for example, Dr. So we are in discussion with them at that level. I think I'll stop there and allow my Honorable Deputy Minister to take over.
Thanks, DG. I'll be very brief. I'm aware that we've gone well over the time allocated. So I'll just comment briefly on the health human resource area, which DG has touched on. Firstly, just to say that we're quite conscious of the fact that human resource for health is a very key aspect of, success of the public health system. And when we talk health human resources, we're not only talking about doctors, but comprehensive team, multidisciplinary team, nurses, pharmacists, physiotherapists, dentists, all of them. So we're doing everything possible to make sure that that area is well taken care of. Of course, this is dependent on financial resources available. So I can just say that in as far as the statutory requirements for those professions which require either internship or community service, we do everything possible to work with provinces to make sure that they are supported, and we do our best at the national level to put pressure on our colleagues in Treasury to assist us in that respect. And as a result of that, in terms of the statutory component on internship, if you look at medical interns and all the other health professions which require internship, we have had good cooperation from Treasury too, and that's why we do have on the conditional grants a statutory conditional grant on human resource, which has enabled us to stabilize, especially your medical interns and community services over the last, I would say, maybe 3 to 5 years. There hasn't been major difficulty because of the fact that we've ring-fenced as a conditional grant to support provinces, and this is protected, and therefore we have been able to fund. I wouldn't say that the allocated funds is totally enough. We do get challenges from time to time, but the area has been fairly stabilized. But there are a number of other areas which we need to relook at. There is also inefficiencies, which we have asked our teams at national, working with the provinces to relook. Some of those, of course, don't make us popular with the organizations which look after the interest of some of the staff. Areas of, for instance, where you have allowances such as rural allowances, some of those are historic in areas where they would not qualify as rural anymore. And also the issue of overtime. We also is an area committed overtime where in some of the facilities, this is taken as part and parcel of the salary, irrespective of the needs. Even when more staff is employed, the people remain on the same overtime allowance. So those are some of the things. Occupational specific dispensation, also a lot of inefficiencies, of course, to deal with this, to get it more aligned to the needs. These are also beyond just health they have to be dealt with also through the public service department. On our side, also a major inefficiency is in the area of remunerative work outside public service, what is generally called RWAPs, which we've also asked the teams to look at, to rein in on where people are paid full salaries, but hardly spend time looking after patients. So let me just leave it there in the interest of time. That I just wanted to add on this area. Thank you very much.
Thank you, Chairperson. I think almost all the questions have been answered, but I just want to add a few. The first question here from Honorable First Speaker, I think, is Honorable Pat. It says we have adopted the Cuban model of NHI. I just want to explain because this is important. Our NHI model is far from that of Cuba. Cuba is far advanced in terms of healthcare in the whole world. We are nowhere near it because the model in Cuba is that all healthcare is free for everybody at any one time when they need it. And there is nothing called private healthcare in Cuba. And their model of healthcare is based on primary healthcare rather than curative healthcare, which we and the rest of the world are doing. And that model has served Cuba very well because quite a number of diseases no longer exist in Cuba, even though I know people are undermining that a lot. Part of the reason why medical students who train in Cuba have to come and do the final year here is because there are lots of diseases here at home which they are going to meet on the very first day when they get into our hospitals. Diseases that don't exist in Cuba at all. And most of them are infectious diseases because Cuba has done away with them, with their model of primary health care. And that's what we are all itching to arrive at, but we are still very far from it. I just want you to understand that. The other issue I just want to touch is about the issue of life is the main. DDG Hunter has already explained some of the things which happened. All I want to add is that in the report of the Health Umbad, Professor Makhoba, he made a recommendation that we need to amend the National Health Act so as to avoid another life is the main. The reason that he said so, honorable members, is that if Gauteng tried to do what they did by removing patients into communities, if they did it before 2002, they would not have been able to do so. It would not have been possible because at that time, the Health Act, which was used, was passed in 1977. And in that Health Act, no mentally ill patient can be moved from one area to the other without a signature of the president. You may remember, honorable members, that there used to be people called the state president patients. Offenders who assassinated Verwoerd came to be classified as that, as the state patient, state president patient, who will not do anything without the signature of state patient. So that's how mental health was run. But in 2002, in our democracy, when the National Health Act was enacted, the belief here, which was not necessarily wrong, but unfortunately led to wrong consequences. The belief was that things are happening on the ground in provinces, hospitals, clinics, they are all in provinces. They are not up there at the national office or even in the presidency. And the question is why then decision-making has to be taken that high up to the level of presidency. So that decision, which used to be exercised by the president, was then delegated right up to the MEC, not even to the minister, where MECs could then have power to make the decisions like this on their own. Now, we believe that should not be like that. But when the department was trying to amend, they looked for legal advice, and the lawyers advised them that because the NHI Act shows that there are going to be 9 consequential amendments, that means 9 acts are going to have to be consequentially amended as a result of the NHI Act. So they said they must now wait for that act to be assented to. And as you know, the president only assented to it in May. So the department will have to sit down to do those consequential amendments. And some of them will be about stopping future life is diminished as they've happened. The other question, I think this is a question asked by Honorable Briet, is about the issue of vaccination, our strategy. I just want to raise it, honorable members, because it's very important. Vaccination is not a luxury. It was very painful to listen to anti-vaxxers during COVID-19. There's always been anti-vaxxers in the world. In some of them, like in the Eastern Bloc, I mean, East Asian countries, some of them were so strong that they actually destroyed lots of communities. For instance, in India, there were anti-vaxxers on polio, and lots of kids were born with polio. I mean, not born with polio, nobody gets born with it. Contracted polio all over the country until something drastic has to be done by a minister there who even wrote a book. Now, vaccination has stopped lots of people. As DDG Jeanette Hunter has already said, many of us, when we were, and she made the issue of age. So people of our age group, when we were at primary school, we used to have many kids who were working on calibers, on crutches. You hardly ever see that in any school. Don't think it was just luck or an act of nature. No, it's because of immunization, especially against polio, that you'll never go to any primary school and find lots of kids who are otherwise normal but working on calibers. It doesn't happen anymore. So we will plead to members to encourage society to vaccinate because it vanquishes diseases. We hardly ever see diseases like tetanus, which were very common many years ago, diseases like diphtheria, even gastroenteritis, ordinary diarrhea. It used to kill 5 million children globally. But now, because we have got a vaccine for that, even though I know the biggest treatment for diarrhea is clean running water, but for areas which don't have clean running water, kids don't usually suffer gastroenteritis and die because we have got a vaccine to that effect. So they are very, very useful. That's why during vaccination, we vaccinate anybody we come across, even those who may not have been in South Africa legally. They are not left behind because in vaccination, you want to vanquish diseases. The issue of how climate change has affected malaria. We all know malaria in South Africa is found in only 4 regions. It's found in Vembe, in Limpopo. It's found in Mopani, in Limpopo. It's found in Ihlanzeni, in Mpumalanga, and it's found in Kanyabude, in KZN. Those are the 4 areas of malaria in the whole country. And all that we are doing there is to make sure that households are sprayed. So regardless of what climate change may do, if we don't spray what you call in-house residual spray, if you don't spray 90% of the houses in those districts, malaria will come back, whether there's climate change or not. And that is the mainstay of our treatment, indoor residual spray with malaria. It has been helping like that for ages. I know the issue of larvicides, which is also helpful because malaria will flourish in areas where there's a lot of static water that is not moving. because that's where they lay their eggs. So as long as we can spray efficiently and maybe even religiously, we will be able to control malaria. The issue of outsourcing, Honorable Chira, this decision of insourcing was taken a long time ago. That health delivery will work better in terms of insourcing. For instance, the whole issue of insourcing food services inside hospitals was not good for patients, because you are insourcing to people whose business is to get money from supplying food in hospitals, and they'll supply as little as possible if they can go away with it. Whereas if you train workers inside who then get what you call raw food and prepare, it becomes much cheaper and it becomes of good quality. And I know I've not yet I've not yet checked the recent score, but I know at that time Limpopo was far advanced because they took a lot of workers and trained them to start cooking food for patients to remove insourcing. Then came the issue of security. A decision was taken that security need to be insourced also, because then private security companies that were hired, they'll just go to the streets and fetch anybody who is not even trained, because to them it's money, it's a tender. You just send a human being there with a uniform and they pretend that the person knows anything about security. Now we won't be able to evaluate security companies. So it's better that we do it in-house. It becomes people who have hired, who we can monitor. But they need training. So you can't just wake up tomorrow and say, I'm insourcing somebody to be a security officer. Security officers need to be trained. You need to be sure of them. So it was happening gradually. It wouldn't just happen by stroke of a pen that we are now insourcing. Even the issue of life is demanding. Remember, life is demanding itself, where patients were removed, was sort of outsourced, because life is demanding is a private company, even though it was doing well, but it was outsourcing. Now, the problem of removing patients from life is demanding to community, to community facilities was even worse, because the community facilities were not trained, at least in lives demanding, even if outsourced. There are doctors there, there are professional health workers who are highly trained. In the communities, nobody was trained, and that's what led to this disaster. And even the inquest came to find that. Then the issue of medico-legal and the issue of birth injuries, I think is a question again by Honorable Chiro. Yeah, there's already been an answer that a substantial number of medico-legal cases is fraud. Some of us have come across that, especially in the Eastern Cape. Some of the claims is outright criminality. We even called SIU to deal with some of these lawyers, and some of them, we really want them to be sent to jail. But the issue of assisting birth injuries, as you're saying, I'll answer it together with a question asked by Honorable Nicola Duplessis, that many people do not get compensated. Yes, that is true. It's because of the model that we are using. The former Director General of the World Organization said this model of litigation that we are using is the worst that America can bestow to the world, bequeathed to the world, because it's an American model where you go to court and fight it out. And most of the money at the end of the day doesn't go to the patient. That I can assure you. In the present model, most of the money end up with the lawyers. A patient maybe is paid 10 million rand for the damage that has been caused to them. And they write during the claim they say for future medical care, this is how much we need, because this patient cannot take care of themselves. They need for a care worker who will come and take care of them. This is what we need. And they add all those things. They even add maybe for a house, because the person cannot live in an ordinary house. But once that money is paid as a lump sum, that patient will never see that future medical care. In fact, the future medical care is based on what private hospitals are charging. Once the money is paid, that patient will be left to go to public hospitals, and the state takes over after having paid cash for huge amounts of money in medical care. But then the person comes back, and you can't send the person away. They won't get any house as it was claimed there. They'll get an RDP house from the state. And so these are some of the problems that are happening. So what are the solutions? The solution is to move away from this shootout approach. I call it the shootout approach because we have got a series of lawyers this side and a series of lawyers that side who are hitting at each other, who are fighting. When we got listeriosis, I got very happy because the company that was implicated in the manufacture, in the Poloni problem, as you know, Enterprise, who owned Enterprise, they came to me and said, let's sit down and talk, because if we do a shootout, the people who are going to gain at the end of the day are lawyers on both sides, the state lawyers and the lawyers of the company. Said they are going to be the beneficiaries. The patients who were affected are going to get very little. But unfortunately, that's the model which in South Africa, the best model which we are trying to pursue is what is called no-fault claim. In other words, where you are putting a claim and not apportioning any fault to anybody, which must be proven in court that indeed is a fault. The no-fault claim consists of putting up a tribunal that usually consists of retired judges, senior advocates, retired professors of medicine, social work, senior social workers. You put them together, they assess the damage on this patient inside the hospital, because all over the world, there will always be some form of damage or the other in hospital. In fact, the World Health Organization has declared that when you are in an aeroplane flying in the sky, you are 300 times much safer than when you are sitting in hospital anywhere in the world. So there will always be problems. And because of that, that tribunal will assess that, yes, in the course of treatment, so and so was disadvantaged by this form of injury, and this is how much they get. The funny thing is that it was discovered that during that method, many more people get compensated than this present method where lawyers go to fight it out in court. And that is the model that we think we are going to adopt, but it needs a whole change of legislation in our country because it's a whole new area altogether. The issue of community health workers was responded to, and Chairperson, the last question by Honorable, the last speaker, I think I didn't pick the name very well, is Honorable Jean, if I'm not mistaken. You asked about the hacking of NHLS. Yes, NHLS has been hacked, our National Health Laboratory Services. The hacking is happening all over the world, unfortunately. Even the most sophisticated countries in Europe have been hacked, where they're asking for ransom. But I don't want to over-exaggerate the effect of this from what we sometimes see in the media. This hacking of laboratories does not mean that specimens are not being tested. No, you can take blood anytime and send to laboratory. It will be tested. What it has affected are the results, because they were automated. Now we are sending results manually. Obviously, many doctors grow unused to receiving results manually after some days. They are used to a situation where they send blood, and then they get the results online much quicker. So we're trying to send the results manually, but they do receive the results and the blood is tested, only that the results are no longer as fast as they used to be when it was, when we were using this, when we were using this system that has now been hacked. We have called in CSIR, the Center for Scientific and Industrial Research. They are working together with other private IT specialists to try and make sure that this problem is resolved and in future it doesn't happen again, because they will have to build lots of firewalls to protect our systems. Thank you very much, Honorable Chair and Honorable Members.
Thank you, Honorable Minister, as well as the team. I just want to alert the Honorable Members, if they feel that some of their questions were not answered, they can send written questions to the department through the office of the Secretary of the Committee. Then I just want to say thank you to the Honorable Minister, Deputy Minister, DG and the team for their presence as well as their presentation and for answering the questions from the Honorable Members. I think we all have now a more clearer picture of the operations of the department. Honorable Minister, we will now request yourself and the Deputy Minister, as well as the team, to log out of the meeting so that we as the committee to proceed with the meeting. Honorable Minister.
Chair, are you releasing us, Chair? I didn't hear very well.
Yes, Honorable Minister.
Okay.
I'm asking yourself and Deputy Minister as well as the team to log out.
Okay, thank you very much. Thank you. Pleasure. Pleasure.
I think all of the members of the team of the department is locked out. So is the committee. Can we proceed in terms of the agenda? The next point on the agenda is the consideration as well as the adoption of the budget vote of the Department of Health. Can I get a mover in terms of the adoption?
Madam Chair, can I just ask a point of clarity, please?
Yes, Honorable.
Thanks, Honourable Chairperson. I was just wondering, before adopting the report, are the committee staff not going to take us through the report, or are you assuming we have read it and then will then automatically, just if we have submissions to make or add anything, do that now? I just want clarity on that process. Thanks.
Thank you, Honourable Member. According to me, we have... yes, Honourable Member. Yes, Honourable Sibanda, you can proceed.
Yes. Chairperson, I think we have an ample time to listen and they've responded to our questions. So I support the idea that we adopt this report because we had enough chance to interact, no matter we are new, but we have interacted. And then also what I have appreciated, they never send this document today. We have an opportunity to read through if there is anything. I rise to adopt the report. Thank you.
Thank you, Honourable Sibanda. Honourable Briat, like we, Honourable Sibanda have said, we have received the report and we should have read the report. So there's a mover for the adoption of the report. Can we get a seconder? Can we get a seconder for the adoption of the report? Honorable Duplessis.
Thank you, Chair. I would second the adoption of the report with the recommendations made by our researchers.
Thank you very much, honorable members. So now we move over to the next item on the agenda. And the next item on the agenda is the first program of the committee. We, as the committee members, did receive it, and it's on the APC. Can I get a mover to adopt this program for the committee?
Chairperson, I will move to adopt.
Is it Honorable Briat?
It is, sorry, Chairperson.
Honorable
Chairperson, I
Briat
will
is moving,
second the adoption.
and that's Honorable.
Honorable Adrianse. Thank you, Honorable Chairperson.
Adrianse is seconding the report. So now the next agenda point is the conclusion of the meeting. So I just want to thank each and every member for their time. And I know this was the first meeting, but I know the next meeting we will try to have it in person so that we do not have all of these problems. Honorable members, can we mute?
Chairperson?
Yes.
Honorable Aris, okay.
Yes, Honorable Aris.
Chairperson, there's just one issue that you please must clarify with the department. Is one, we cannot have people from the department that must come and report to us while they're busy sitting in their cars and driving and things like that. It says to me that they are not serious with what we are busy with. And secondly, we must make sure, because we all know that it will be an official meeting, that we are in a quiet place, because we cannot tolerate this, that we be disturbed by background noise and things, that all of us are in quiet places. Please, can you just address this? Thank you.
Thank you, Honorable Member. We'll make sure of that. So, Honorable Members, without wasting any time, I just want to thank each and everyone for their presence in the meeting. So the meeting stands adjourned. Thank you very much, Honorable Members.
Thank you, Chairperson.
Goodbye, colleagues.
Bye-bye.
Bye.
Yeah.